Good afternoon, everyone. So I thank Kumaravel sir and the Receptor team for the opportunity. So I'll be talking about nutritional intervention for remission of type 2 diabetes mellitus. So more of a ideal pre-lunch talk, but I was a bit late. So I'll be presenting it post-lunch. I believe there is a small narrow interval between the end of your lunch and the onset of sleep. So I'll try to squeeze my presentation in that narrow time frame. Definition of remission, and I recently came to know that there are 100 different definitions of remission, and it's not an overstatement. There is a paper that says that there are more than 100 different definitions of remission. So whenever we come across any paper that deals with remission, it's essential to know what kind of or what level of remission that they are talking about. So most commonly followed one is ADAs. They gave definition 1 in 2009 and 21. So the 21 definition is this: return of HbA1c to less than 6.5% that occur either spontaneously or following an intervention, and that persists for at least 3 months in the absence of any therapy, pharmacotherapy, right? So basically from 2009 to 2021, the definition has become very simple. In fact, it has become too simple to the point of, I would say, obsolete, right? So the major reason why they have simplified so much from 2009 to 21, in 2009 we got one term, that is partial remission, whereby the patient has blood glucose below the diagnostic threshold for diabetes, but that can roam around somewhere in the pre-diabetes territory, and they required at least 1 year duration of that remission, something like menopause, right? Then came complete remission, where they want the blood sugars to fall below the pre-diabetes threshold, and prolonged remission when that complete remission lasts for 5 years. Now that has been made simple into one single definition and one single number, that is HbA1c less than 6.5% for 3 months without therapy. And even going by the paper itself, the reason why they have simplified is not that we have become wise within the intervening years. They just want to simplify it for the insurance purpose. So most of the time when you have that label of diabetes or pre-diabetes, as I learned from that paper, that in Western countries covered by insurance, the premium cost goes up, or most of the patient will not have luxuries of some of the insurances. So just for insurance recoding purposes, they have changed the cutoff. Now anyone below that category, they can be easily recoded into diabetes in remission. They may remain in follow-up and they can enjoy all those luxuries of insurances. And alternatively, if you are looking for fasting plasma glucose, the cutoff is less than 126. And CGMS, they took only estimated A1C less than 6.5%. So the definition came in 21. So there are a lot of problems with this current definition. One, our entire management principle, now we keep repeating it to ourselves as well as the patient, that we are moving from the numbers of blood glucose. We have moved from the glucose-centric approach towards the risk addressal as well as the cardiorenal protection. But giving a remission is, again, it's not a diagnostic threshold, it's a management principle. So giving a number, one simple number just for the purpose of defining remission, is more like a regressive approach, moving to again towards the glucose-centric or the number-oriented cutoffs. For example, a patient who will be on SGLT2 inhibitor or GLP-1 analog, and the patient goes in for the so-called remission cutoff less than 6.5%. Now we are not giving these drugs for this patient just for the purpose of lowering blood glucose. We also want them to have cardiorenal protection in the long run. Once the patient goes into this, below this threshold, there is a natural tendency, both from the doctor's perspective as well as from the patient side, that they would like to go off drug. Now, we know that even the pre-diabetes range, the risk persists. So what to do with these patients, depending on the cutoff, we have to take away the drug, the patient will not enjoy the benefits of cardiorenal protection with this molecule. So that is a major problem or caveat that has been addressed even in that paper itself with this current definition. The second one, again for the same sake, we know that even the pre-diabetes range, the risk persists. So should we adopt more stringent cutoffs, say achieving normoglycemia for defining remission? That is one take. And second one, we are already moving away from HbA1c now. Giving a single HbA1c target for defining remission will not last long. Probably we should include time in range and other CGMS metrics to take care of the glycemic variability part. And there is absolutely no mention of the bad kind of remission. patient develops CKD, long-standing diabetes, the blood glucose goes down, and we take the patient off drug. That is not the good kind of remission. That is a bad kind of remission, right? But if you just think about the remission definition, even those patient comes into the domain of remission. So probably there should be a caveat in the definition that mentions that all kind of remissions will not be good always. And the last two, specific to our community or our part of the world, once you take the patient off drug, it's very difficult to keep them in follow-up. They will think that they got cured no matter what you say. And follow-up conundrum. In insurance-covered countries, even when they label the patient as having diabetes in remission, still they will be eligible for all the yearly follow-ups and the routine checkups. And how to follow up our patient once we label or give the tag of remission. Already once they see normal sugar, they tend to stop the drug. So these are all the things, the problems with the definition. But considering all this, is remission significant? Considering the load of patient, there is literally a storm coming towards our way. So by 2045, almost literally all the person in this room will be having either pre-diabetes or diabetes. So considering the cost incurred by the health infrastructure, any amount of time span in which we will be able to take off the drug will be a huge economic relief for managing these patients. So considering that, remission is definitely significant. And even when we are not very much keen to introduce this term or accept this term, patient will be anyway know about this term because of social media. There are a lot of brain opening program. So before they open the patient's brain, we should at least seed the thought of remission. We should educate them when we see them first regarding the term remission and the shortcomings associated with the term remission. Again, significance of remission. Once you consider that the fact that some of our patient can actually goes in for remission, at least in the early part of the disease, again the management principles need to change. For example, once we receive a patient of type 2 diabetes, we generally prepare them for a long haul. We say them that it's a long-standing disease. It will progress no matter what you do, and the patient may or may not need to remain on drug for a long time. So that all these things and related things constitute the chronic care model. Now imagine some of these patients have to go for remission. For a short term, they will be off drug and they may have to come back again to the therapeutic part. Then probably the management of diabetes may move to something like ischemic stroke management, where we try to thrombolize them in the initial hours. When we are not able to do that, then we switch over to the chronic care model. So probably the management of diabetes with inclusion of remission might change in near future. So these are the approved intervention for remission: surgery, lifestyle modification, and drugs. Surgery is the one that brought the concept of remission, so the most effective one and the least preferred, both by the patient and from our side, because of the attenuant risk and even up to death can occur in some of the patients. So unless the patient has grave emergency for weight reduction, we don't prescribe surgery, and there are definite cutoffs for that. Lifestyle modification often preferred by the patient because it does not contain any medication, but most of the time patient will not be able to live up to their expectation as well as our expectation. And now we have got excellent drugs. The drugs that can induce weight reduction up to a point of remission, especially tirzepatide, now recently launched. So when I talk about myself or most of the people, when I talk on behalf of most of the people, generally giving a drug and making them lose weight so that they could go in for remission, even if it is short term, will be more attractive because that does not rely entirely on the patient itself, right? So regarding intervention and the temporal events that can define remission, for pharmacotherapy, you need to stop the drug for at least 3 months. For surgery, at least 3 months after the procedure and 3 months after cessation of drug therapy, you can call the patient as having remission. For lifestyle, the lifestyle intervention needs to happen for at least 6 months, and drug therapy needs to be stopped for at least 3 months before you call the patient as having remission. Now coming to the topic proper, nutritional intervention for remission. So nutrition comes under the part of lifestyle modification, diet and exercise. But comparing the two, I think dieting is much more easier than doing exercise. It's very difficult to burn all the calories that you consume, and it's probably easier to reduce or restrict your calorie, at least in the long run. So the concept of nutritional modification for inducing remission of diabetes is not new. Way back in 1976, a group of authors actually noticed that by employing protein sparing modified fasting, we can actually make some of the patient go in for remission. The patients are given only protein and fluids with multivitamin and mineral supplement. They were not given any carbs or fat. So even that was seen to improve diabetes control. So that was the onset of this nutritional manipulation for inducing remission. So the basis of nutritional intervention again for inducing remission comes from bariatric surgery group. In fact, Walter Puri, the father of bariatric surgery, was the one who first proposed that rapid normalization of blood glucose and weaning off of drug happens even before the patient starts losing in weight. But initially this weight reduction was thought to be because of enhanced incretin response or changes in intestine structure, whereby the patient the food that the patient consumes will not remain in intestine for a longer time because of rapid transit malabsorption, kind of malabsorption happens. So those were the reason that were given why these patients were able to go off their drug even before weight loss sets in. But now we know that it's not because of all these things. Even in fact, the incretin response mainly accounts for postprandial hyperglycemia. But the ability to remain off drug depends on correcting the fasting blood glucose. So actually, the significant calorie restriction that these patients undergo before and immediately after undergoing the bariatric procedure, actually that is the reason why most of this patient goes in for remission even before weight loss sets in. So this forms the basis of twin cycle hypothesis. One cycle happens in liver and the other cycle happens in pancreas, and they actually promotes each other, resulting in a vicious cycle where diabetes and all the insulin resistance happen. So in short, when a patient is subjected to chronic calorie excess in a predisposed individual who has some degree of resistance that has been conferred genetically, all these excess calorie eventually will result in excess liver fat deposition. So there is a critical threshold. When the fat gets accumulated beyond the threshold, it starts showing resistance to insulin. You know, insulin is the one that promotes de novo lipogenesis as well as that controls your hepatic gluconeogenesis. So when liver experiences resistance, there will be a continuous output of glucose. At least the fasting plasma glucose marginally increases because of unabated hepatic gluconeogenesis. So this enhanced hepatic gluconeogenesis again rises the basal insulin secretion, because the liver experiences selective insulin resistance, whereby the liver's response to suppression of hepatic gluconeogenesis is not lowered, but it tends to promote de novo lipogenesis. The excess insulin actually promotes de novo lipogenesis, so it results in accelerated liver fat accumulation. So these excess fat gets liberated in the form of VLDL, and triglyceride gets accommodated or accumulated in the peripheral tissues, including beta cells. So that impairs the postprandial response or the glucose dependent beta cell response, which results in postprandial hyperglycemia, which again drives the hepatic gluconeogenesis. So this is how the twin cycle hypothesis goes. So there are a lot of dark spots that actually it's not that simple. We may need to we may need to know more about this principle. So basically, calorie restriction or nutritional intervention reverses this twin cycle by lowering the excess calorie. It lowers liver fat. So the ectopic fat deposition gets lowered, beta cell gets rejuvenated, and they produce enhanced insulin secretion. So the basic funda of this remission happens because of our improved understanding, because previously we thought that at the onset of hyperglycemia and type 2 diabetes, the beta cell dies. Now we believe that it's not actually getting washed away or it's not getting apoptosis. It actually gets trans differentiated into alpha cells or de-differentiated into endogenic progenitor cells. Now when we reverse the twin cycle, there is a certain period of time, at least in the course of diabetes, where this trans differentiation and de-differentiation can be reversed, and the beta cell actually gets back its ability to function as beta cell. So that is the window of time where we can induce a remission, at least as per the currently available studies. So what are the strategies for nutritional intervention? We can either go for low calories or low carbs. And when we come for calorie, it can be low calorie or very low calorie diet. And then we need to know about the durability of remission and the predictors of remission. Low calorie versus low carb, the high carb diet is nothing but the usual diet that we take. Any amount of restriction that we do in trying to lower the carbs constitutes the low carb diet. For calorie restriction, calorie control diet, where we try to take less calorie than the daily expenditure. Low calorie diet, typically the calorie intake falls between 800 to 1200, very low calorie, less than 800. Now, even for routine diabetes management, we clearly know that this lowering of carbs provides only short-term relief, short-term glycemic benefit. So calorie restriction is the base, and food portion control is again the second common thing that we employ before going in for carb restriction. So even the few trials that have shown benefits of remission with low carb diet, those benefits were achieved mainly because of weight reduction and calorie restriction, not because of per se low carb diet. So there is no question, low carb diet we predominantly rely on low calorie diet for inducing remission. And a typical VLCD protocol is very tedious. We need to employ 12 to 16 weeks of liquid diet before switching the patient into a solid diet. Again, because we keep the patient, we change the entire meal profile and the consequence of this liquid diet differs. It's generally considered safe under medical supervision, but standalone as a, just like the Herbalife and other things which patient takes by themselves, it's considered not safe, and there are some serious adverse events associated with very low calorie diet. So evidence for supporting remission of diabetes with very low calorie diet, actually again the counterpoint and counterbalance study, these were the study that was done to test the twin cycle hypothesis that I explained earlier. So the counterpoint study is the one that clearly showed the benefit that for a short time when you employ very low calorie diet, we can actually make the patient goes in for remission. The participants were having diabetes for less than 4 years. The study duration was very short, 8 to 12 weeks. Counterbalance is a follow-up study where they showed that remission achieved with the intense very low calorie diet in the initial period was maintained up to the period of 6 months. As you could see, the number of participants are very low in this study, but in counterpoint at the end of intense phase of very low calorie diet, nearly 100% of them achieved remission. But in counterbalance study, by the end of 6 months, 60% of them, even that number should be great. Compared to the normal arm, nearly 60% of the patient had remission. And this counterbalance study divided the patient into two halves, less than 4 years and more than 8 years duration of diabetes. And the remission rate was higher in those having lesser duration of diabetes. Average weight loss that was associated with remission in these studies are around 15 kgs. So what about feasibility of VLCD as remission induction in primary care setting? Or in other words, what is the scalability of success with VLCD in routine diabetes setting? Most of the patient gets treated in the primary care setting. So any attempt in large scale remission induction needs to happen or needs to be proven in the primary care setting. So we got that data from the DIRECT trial, a diabetes remission clinical trial from UK. It was exclusively done in primary care setting, probably one of the first large-scale RCT that followed patient up to 24 months, and even last year we got the 5-year follow-up results. So it included around 150 patients in the intervention arm. Again, similar protocol as very low-calorie diet, liquid replacement followed by solid food reintroduction and weight maintenance. So at the end of 1 year, remission rate in the intervention group was around 46% compared to only 4% in the control group. Mean weight loss not as prominent as the counterpoint and counterbalance. It was around 10 kg, but it was sufficient to induce remission in nearly 50% of the patient at the end of 1 year. More than 15 kg weight loss was seen in 25% of the patient, and nearly 74% of them went off OAD and 48% of them went off antihypertensive drug. And this remission rate, a remarkable rate of remission was seen even at the end of 2 years. Nearly 36% of them continued to have remission, and the 5 years follow-up that was published last year again showed nearly 13% of them remained in remission. So again, a similar trial that came after DIRECT one is Diadem trial. Similar study, but they adopted a more stringent HbA1c target that they included normoglycemic range with a A1c of less than 5%. So at the end of 1 year, nearly 33 or 1/3 of the population with VLCD was able to achieve even the normoglycemic range of remission. So what about can a less intense calorie restriction yield remission? We still awaiting large scale study in this topic, but going back, even before publication of DIRECT trial, we got Look Ahead trial, which is a primary intervention trial, whereby which is probably for a primary prevention trial, which studied 3-point MACE in type 2 diabetes patient of varying duration, and they assessed the effect of intense lifestyle modification that includes intense exercise protocol as well, which was not there in the previous study, compared to the standard care, and they received around 1200 to 1500 kilocalories. So that is not definitely very low calorie. In fact, that is approaching the normal calorie intake. So remission is not a primary endpoint, but when it was analyzed as a post-hoc analysis, at the end of 1 year, 11.5% of them remained in remission, and at the end of 2 years, 9.2% of them remained in remission, despite not lowering calories to a very low level as seen in VLCD. So this kind of calorie restriction is actually not associated with those attenuant risk that was seen in VLCD. But we cannot compare direct results with look ahead directly because despite having very low amount of weight difference at the end of trial, the remission rate was much different. That is because the population of these patients included were much different in that look ahead trial included patients with long-standing duration of diabetes. Many of them are insulin users. Such patients were actually excluded from the direct trial. So Indian data, there are a lot of studies, but I just wanted to highlight Vijay Sarthi sir's paper. He did modified fixed calorie intake of around 1500 kilocalorie per day along with 1 hour of advised walking. It was not supervised, just suggested. And the patient included were around 28 who had mean age of around 24 years, so very young people with a duration of diabetes less than 1 year. And as you could see at the end of 24 months, the patient population, the young chaps, achieved a mean weight loss of around 8 kg and the remission rate at the end of 1 year was up to 50%. So again, mean weight loss at the end of 2 years in this study was 8.2%. That was comparable to the direct trial, even though the degree of a magnitude of calorie restriction was not that low as seen in direct trial. Up to 1500 kilocalorie per day were allowed in this Indian trial. So what about the predictors of remission? If you are going to employ remission as a strategy in our routine practice, we just need to know what kind of patient carries that better prognosis for remission. Just like when we treat Graves, we just know that some of the patient has certain characteristics that will tell us that these patients can go in for remission only with pharmacotherapy. Similarly, if we go by the studies, duration of diabetes is the single most factor that determines the reversibility of beta cell dedifferentiation. So anyone having early onset or early or young, recent onset diabetes, they carry greater likelihood of remission. The second predictor is severity of diabetes. Anyone having insulin or having higher HbA1c, lot of drug loads, having using lot of drugs, the chance of remission is low. But if you go by Sarthi sir's paper, many of his patients actually had a baseline HbA1c of 10%. But with that intervention, 1 year intervention, they actually achieved 50% remission. So probably the young age of those patients may be the factor why they were able to go in for remission. Age is not a consistent predictor, but younger the better it seems. And degree of weight loss, we need at least 10 to 15 kg weight loss for a long-term durable weight reduction. But even with 8 to 10% of weight reduction can result in remission in some of the patient. Again, weight maintenance or maintenance of lost weight is the major determinant of durability of remission. There are two unanswered things. One is baseline weight and baseline calorie intake. So I personally feel that those who have higher baseline calorie intake or those who have higher baseline weight, they respond better with remission rates with these intervention. I think now we almost believe that if you have diabetes, it's better to be obese than be lean, because the management options are much better for an obese person with diabetes. We have tirzepatide, we have all these nutritional intervention that can be freely employed in those in obese patient, more like heart failure with preserved ejection fraction, where the therapy options are limited. So to summarize, remission seems practically achievable target as of now, at least in newly diagnosed or recently diagnosed type 2 diabetes patient who are young in age. And nutritional intervention, a combination of nutritional intervention and pharmacotherapy seems attractive in primary care. And the intensity of low calorie diet that we discuss as of now, it need not be very low calorie diet or the kind of calorie diet that requires frequent monitoring or registered qualified nurses. So even in primary care setting, even when we could reduce the calorie of the patient baseline intake to 1200 to 1500, we may be able to achieve remission. So we need to generate a guided awareness about remission among all our patients, especially the one who comes for the first time with diabetes. As such, the definition needs a lot of refinement, and the cutoff, probably we need to target a normoglycemic range and not the A1C of less than 6.5%. So with that, I wind my presentation. Thank you.